All right. Welcome, everyone. Thank you for joining the Provider Advisory Committee meeting today. For those who haven't met yet, I'm Dr. Gary Tsai. Have the privilege of serving as the chair for this Provider Advisory Committee alongside Commissioner Madrigal-Weiss, who is our co-chair. We just want to begin by thanking each of you for spending time with us this morning to help shape the work of this committee. Um, we have a lot to cover as we do normally, and so we'll just jump right in. We'll take roll, officialize the quorum. Also, please note that under the Bagley-Keene Open Meetings Act, committee members who are participating remotely must keep their cameras on at all times. Getting some background noise. Thank you. So committee members who are participating remotely must keep their camera on at all times and will be asked during the roll call to disclose if they have any other adults age 18 or over in the room with them during the meeting and the nature of their relationship with those individuals. With that, Sandra, we're going to take roll.
Thank you. Good morning, commissioners. All of you are participating online, so please unmute your lines for a quick roll call. Commissioner Baer.
Here.
And is anybody over the age of 18?
No.
Commissioner Burnick.
Right here, and no one else here with me.
Thank you. Commissioner Chambers. Marked absent. Commissioner Designee Swartz. Marked absent. Commissioner Cross.
Here, and I'm alone.
Thank you. Commissioner Fernandez.
Here, no one else with me.
Commissioner Madrigal-Weiss.
Here and alone.
Thank you. Commissioner Tsai.
Here and alone.
Thank you. We have quorum.
Great. Thank you, Sandra. Okay, moving on to agenda item 2, announcements and updates. As a reminder, we are abiding by Bagley-Keene Open Meetings Act for these meetings. But as we've discussed in prior meetings, as part of our commitment to deeper public involvement and engagement, today's meeting of the PAC, or Program Advisory Committee, will relax its use of Robert's rules to allow for more flexibility and more open public comment and dialogue. We hope this will help to promote and encourage feedback between the committee and the community. This change, which we've been doing since we've been meeting, so it's not a change from what we've already been doing, but more for people who may be joining new today, fulfills a commitment made by the commissioners to try to strengthen transparency and create more accessible two-way communication between the committee and the public. So, any and all feedback is welcome. We do ask that people try to keep their comments as succinct as possible. As we've done in prior meetings, we won't have a strict 1 or 2 minute rule for now, but if we start running short on time, we may have to institute that. So just a respectful ask for people to try to keep comments as succinct as possible. The other key update that is important for us to highlight is that we plan on sharing key updates from each of the other 4 committees in moving forward, just so that participants of the committees have a sense of the work in progress that's going on. I think from recent commission meetings, we've recognized that it's probably helpful for everyone to be aware of what is happening in each of the committee meetings, and that it can be difficult for everyone to read minutes and things like that. And so basically, we'll be at the start of our agenda for this PAC meeting, as well as future PAC meetings, providing some key highlight summaries of each of the other committees that have been shared by the chairs of those committees. My understanding is that those committees will also be providing summaries. So, for example, if you attend another committee meeting, you would also hear a similar update on what's happened in the PAC. And so this is really just an effort to try to get everyone on the same page in terms of what's happening in each of the different committees. And so with that, if we could just bring up the committee highlight slide. So that was a little bit of context for this slide. And this slide outlines the 4 different committees You can see, well, actually, I think there's 5 different committees because we're not on here because we know what's going on in our committee, hopefully. For the Budget and Fiscal Advisory Committee, there was a presentation on the 2025-2026 mid-year update. And actually, just for clarification, this is for today, is that right?
Correct.
Yeah.
It'll be, I thank you, Commissioner Sy. This is Brenda Grealish. This will be for our Budget and Fiscal Advisory Committee that will be taking place at 12:30 today. We'll have our Legislative and External Affairs Committee following that, and then the Client Family, Community Inclusion, Lived Experience and Diversity Advisory Committee, and Workplace Optimization Advisory Committee may be meeting next week.
Great, thank you. So what I'll be describing is actually what will be covered. So for the Budget Advisory Committee, there'll be a presentation on the 2025-2026 mid-year budget update, as well as a presentation on the 2025-2026 spending allocations, giving an overview of financial priorities and planning for the upcoming year. For the Legislative and External Affairs Advisory Committee, they'll be considering bills that the commission may choose to support or oppose in the 2026 legislative season. They'll also be providing an update on the early psychosis intervention video project, which focuses on promoting coordinated specialty care for early psychosis intervention programs. As Brenda had mentioned, on February 24th, the Workplace Optimization Advisory Committee will hold a closed session and hear from Human Resources regarding workplace wellness matters. And then on February 26th, the Client, Family, and Community Inclusion, Lived Experience, and Diversity Advisory Committee will have a focused discussion about the future structure of the committee, explore ways to strengthen inclusion and representation moving forward. They'll also have a discussion to reflect on the effects of BHSA implementation on peer-run organizations. Lastly, the full commission plans to have a 2-day meeting in January. A 2-day meeting held on March 26th and 27th in Sacramento. So that concludes our announcements this morning. Just want to thank everyone for coming today. And again, we'll move on to agenda item 3, which is general public comment. This time is reserved for comments on items that are not already on the agenda today. Claire, you want to lead us in public comment?
Thank you, Commissioner Sy. If you'd like live meeting transcription or closed captioning, please activate the closed captioning feature located in the control bar at the top or the bottom of your screen. If there are any members of the public using translation technology, please notify the chair so that we can be mindful of that. You may request to make public comment by submitting a card if you're in the room, clicking the raise hand icon on your computer or the app, or if calling in by phone, you can press *9. Members of the public can also email us public comment to be shared at a future meeting, and that email address is publiccomment, all one word, at bhsoac.ca.gov. Are there any comments in the room? There are no comments in the room. Are there any comments online? We have one comment online. I appreciate that you're going to be able to comment, and I'm going to unmute you. Norit?
Hi, yes. Good morning, all. My name is Norit Admasu, and I am with NAMI Urban LA, based in the LA area. I am here attending today, and I'm grateful to be part of this space. But I wanted to raise that, I'm a member of the community planning team for BHSA on the local level with the Department of Mental Health. And we have a really robust community engagement on the local level. And I was wondering about plans that this state committee has to engage with the existing community planning teams. Each community planning team is very thoughtfully, recruited and fostered, and we have really, as I said, robust engagement. People are committed to attending. It's very time-intensive commitment. And we have deep discussions about the stakeholder communities we represent. So it seems, maybe like there could be some engagement that happens on the state level to leverage these existing community planning teams, especially as prevention gets, is a lot of the prevention dollars are going to be administered directly from the state. So just wondering about plans to leverage those existing community planning teams, to have the community engagement process a little bit more seamless, because it seems like a lot of important voices may not be coming to the table from LA, and that's one major constituency, but I know it's probably even more so with other community members across the state. So just wanted to raise that, and hopefully get some follow-up on what the plans are to engage us on the local level.
Thank you, Norit.
We have no further comments.
Okay, great. Thank you, Claire. Agenda item 4, moving on, is to review the meeting minutes from the last Provider Advisory Committee from December 15th. At this time, I'd like to invite committee members to offer any comments or ask questions. Any comments or questions on the meeting minutes? Seeing none. Claire, I think we can move forward with opening up for public comment.
There are no public comments, neither in person nor online.
Okay, thank you. With that, I'd like to invite Sandra to take a vote on the minutes.
Great. Committee members, please. Commissioner Bear.
Aye.
Commissioner Burnick.
Yes.
Did we make a motion to accept them?
Marked absent. Commissioner Designee Swartz. Marked absent. Commissioner Cross.
Yes.
Is it here or yes? Aye.
Aye.
Commissioner Cross. Aye. Okay, thank you. Commissioner Fernandez.
Aye.
Commissioner Madrigal Weiss.
I just want to be clear. I didn't hear. Did we make a motion to accept them?
Oh, shoot. That's. Thank you, Commissioner Madrigal Weiss. We
Of
did not have
course.
a motion.
I will make the motion to accept the minute.
I'll
We have a
second it.
Madrigal Weiss with the motion. Who was the second?
Cross. Commissioner Cross.
Thank you, Commissioner Cross. We're starting again. We have a motion on the table for the Program Advisory Committee to approve the December 15, 2025 meeting minutes with a first motion and a second. Commissioner Bear.
Yes.
Commissioner Burnick.
Yes.
Commissioner Chambers. Marked absent. Commissioner Swartz. Marked absent. Commissioner Cross.
Yes.
Commissioner Fernandez.
Aye.
Commissioner Madrigal Weiss.
Aye.
Commissioner Sai.
Aye.
The motion passes, and thank you, Commissioner Madrigal Weiss.
Thank you, Commissioner Madrigal Weiss, for catching that. All right, agenda item 5. We'll be hearing about the Department of Healthcare Services Behavioral Health Transformation, or BHT, performance measures. Just as a reminder for folks who may not have been tracking this as much, this is a statewide continuous improvement strategy. DHCS, in collaboration with counties and other stakeholders, has established 14 behavioral health goals and performance measures. These are designed to guide planning, set priorities, ensure accountability in the use of behavioral health funding and services. We welcome Anna Nafee today from the Quality and Equity Workstream, the lead for the Quality and Equity Workstream work around BHT at DHCS. She will be providing an overview of these performance measures and explain how they'll be leveraged to advance progress and promote equity under the BHSA. Welcome, Anna. Appreciate if we can aim to try to spend maybe no more than 15 minutes or so, 15 to 20 minutes on the presentation, just so we can have time for discussion. Thank you, Anna.
Okay, thank you. No problem. Hi, everyone. I'm going to go ahead and share my screen. How's that looking? Nope.
Don't see it yet.
Seen it yet.
Yes?
It's coming, Anna.
Yeah, there it is. Yep.
Okay, perfect. So thank you so much for having me today. And I'm glad to see so many familiar faces and friends. So I am here today to talk about the quality and performance measures that we're developing for behavioral health transformation. I'm, like I said, Anna Nafee, and I'm a consulting psychologist with the Department of Healthcare Services in the Quality and Population Management Division. And I'm the lead for our quality and equity policy and development of the measures for BHT. So I'll try to keep it under 20 minutes today, but just to do a little bit of an overview of the work, I'll talk about what we call our phase 1 and phase 2 measures, and then spend some time on Q&A. So first, we'll start with a little bit of background. So in terms of behavioral health transformation and Prop 1, as you know, there are many components to the changes of the MHSA to the BHSA. And then there's also a call for increased accountability and transparency. And so my work and our work in the department is really focused on that accountability and transparency part of the initiative, as well as implementation of a population behavioral health approach. And I'll talk about a little bit more about what that means here. But this is furthering the work of CalAIM and some of the other whole person initiatives that have happened statewide over the last decade or so. So specifically with the BHT work, where we're really thinking is in order to implement the measures, we want to embed the measures within the broader vision of the department and for the state of what we want from our behavioral health care services. So specifically, all Californians have access to behavioral health care services, leading to longer, healthier, and happier lives, as well as improved outcome and reduction in disparities. So we started with a vision, and from there set forth a set of goals. And those goals are meant to help us all, the entire state, align on particular activities and outcomes that we aim to achieve from our behavioral health system. And so that includes across our behavioral health plans at the counties and managed care plans, including public health. And really the idea is that we, from those goals, can start to think about how we might want to measure those things and then develop those targeted interventions that we think would make an impact on those goals. And then continue in a quality improvement process with those. So the goals that we've set forth are really for the entire public behavioral health system, including specialty and non-specialty care system, and SUD services, as well as other system partners. So we have a number of goals that are really broad reaching and at the population level. And really the concept here is that no one system can accomplish these goals or make effort and movement toward these goals. That really the underlying premise is that we would expect a lot of community collaboration and partnership in order to achieve the kinds of outcomes that we want to see. So we talked a little bit about a population health approach, and the idea here is that, you know, we're not only anticipating that we would be able to serve or have impact on people who are currently engaged in services, people with significant behavioral health needs and connected to our systems. We also want to think about how do we identify and outreach and engage people who may benefit from services who are not yet connected. And so a key strategy here is using our data, using also Medi-Cal Connect as a tool, which I can talk a little bit about down the road, But being able to identify people who may benefit from services, being able to identify and stratify by risk and needs, and then thinking about whole person care. So connecting people with services that they may benefit from, including things like food accessibility or housing. We want to encourage the coordination across systems with our data, and then also to engage in continuous quality improvement, as well as to identify and reduce disparities. So we are working on strategies that we can help to be able to stratify and be able to identify where those gaps are across the state and at the local level, and then target those disparities. So these are the 14 behavioral health goals. These are largely established from the legislation, SB 326, in particular, the goals for reduction. So the goals are really targeting the priority populations of the BHSA, as well as the outcomes that we aim to see. There are some goals on the goals for improvement side where we really heard from a lot of stakeholder engagement that things like quality of life and social connection are really important for wellness and recovery, and resiliency. And so we have those included here, as well as engagement in school and engagement in work. Across these goals, we are identifying strategies to improve health equity. We had talked about in the beginning whether health equity should be its own goal, and landed on in conversation with our partners that it would be really important to have health equity spread across all of the goals. So the idea is that these goals are goals for, like I said, our behavioral health plans, as well as our managed care plans and public health. And so all of the partners are now working on identifying strategies to address these goals in concert. So to start, we wanted to have some measures that we could produce and share with counties and managed care plans to begin the planning efforts of the BHSA, understanding that the first integrated plan is due next month. And so we started with what we call phase one measures. So phase one measures are measures that we identified from the public domain, from websites and sites like the Department of Public Health or the Department of Education, the Child Welfare, and identified a set of public measures that we could use to begin to inform planning processes. So the measures that you see as phase one measures, this is what counties are currently using in their integrated planning. They're looking to these publicly available measures to identify at a population level, are they above or below, for instance, suicide rates across the state? And then developing plans to address those needs. The phase one measures are only meant to be temporary, as we're working now on the development of phase two measures. So once the phase two measures come on board, the phase one measures will sunset. Phase two measures specifically are using individual level data that's being calculated by the department in Medi-Cal Connect and shared with plans. And they're attributable to behavioral health plans and managed care plans so that we can understand which part of the system is accountable for which part of the measure performance. We're aiming for a measure set of about 50 to 70 measures, which is a large measure set. And I'll talk a little bit more about how we landed with that. But the phase two measures are used for planning purposes, similar to the phase one measures, but they're also used for population health and accountability. And ultimately, that's where we'll get to, is the accountability. The other thing about phase two measures is that we're linking external data sets to claims data, and we'll be able to look broadly across data from other state departments to be able to identify performance and outcomes. So I've talked a little bit about how both phase one and phase two measures can be used for planning purposes. Being used for counties in the integrated plan. Managed care plans are also using them in their population health management deliverables that they're submitting to the department. So there's similar work happening in parallel across systems. But phase two measures in particular are useful for both population health and accountability in that the phase two measures can be divided into and disaggregated into individual level identifiers so that we can understand of the people who are included in the measures. Who are those individuals and how might we engage those people who are eligible for services who are not receiving services to both improve the person's life, but also improve the performance on the measure. Similarly, the phase two measures are used for accountability in terms of monitoring BHSA funding expenditure, progress over time, as well as being incorporated into the behavioral health and managed care plans accountability sets, the BHAS and MCAS accountability sets. Not all of those measures will be included. Only a very limited subset of measures are included. Okay, so I won't spend too much time on this. I'll sort of glaze through these slides. Phase one measures have what it's called primary and supplemental measures. This was really just used to help guide the planning process. The primary measures are sort of the core measures that we expect the planning to center around, and supplemental measures help support and provide additional context. We developed and provided a workbook as well as a guide and manual to help support the use of the phase one measures. So the workbook, all counties have access to it, and it's available on our website. That it has all of the measures, all of the rates for all of the measures in all of the counties, as well as a calculated statewide rate. So all the counties can look to see how their performance is in relation to other counties and a statewide rate. So those links are available. This is just a little bit about the integrated planning. I think what's important in terms of the integrated planning process is really the alignment of using the measures to help guide the planning and the alignment across the behavioral health plans and managed care plans and local health jurisdictions to be able to sort of have a common language across the goals in the planning process. I'll keep going here. And then this is the timing for the integrated plans. So the integrated plans, the draft of the integrated plans are due in March, as you know. And so they're starting to flow in. And then the final is due in June and become effective July 1st. I'm going to skip through phase one measures in the interest of time and continue to phase two measures.
And sorry, Anna,
Yeah.
real quick. I think we can give you maybe an additional 10 minutes, so half an hour, if that helps in terms of covering the
Okay.
content in your slides.
Okay, that's fine.
Thank you.
I could go on and on. Okay, so we started with in phase two, in order to design the measures, we started by dividing the 14 measures into 3 cohorts. And so we have phases and cohorts and all kinds of things. So the cohorts were really just designed to help us sort of chunk the work and move through the measure identification and specification process so that we could select the measures over time. We have selected the measures for phase two for the first 10 measures on the left of this slide. And I have them here. I can share them today. We're working right now on cohort 3 and on a set of equity measures that we are planned to finalize by the end of June. And in terms of the equity measures, we have two things in particular that we're focusing on for equity in the measurement part of this work. There's other policy work that happens. But for the measurement part, We anticipate that all of our measures will be stratifiable in Medi-Cal Connect and available to plans across a number of key demographics. But then we're also looking to develop a set of about 4 health equity uh, measures that would be bold goals for the state to be able to close gaps on key areas. And I could talk a little bit more about that, but the idea is that we would set targets for areas where there are key disparities and aim to close those gaps across the state over time. In order to do this work, we established a Quality and Equity Advisory Committee, and we have a few members actually of the committee here. And this committee consists of managed care plans and behavioral health plan representation, advocacy groups, and then we have a number of experts in developing performance measures and researchers, as well as people with lived experience in behavioral health to help guide the development of the measures. We have three subcommittees. So we have a technical subcommittee that helps us with the measure specifications, a theory of change subcommittee, and I could talk about theory of change. It's the logic model that we use to develop the measures, and then a specific equity subcommittee that's just launched. Okay. So I mentioned a little bit that the performance measures are being used, being developed with claims enrollment data and other Medi-Cal data sources, as well as individual level service data on the BHSA. And data, it will be linked to data from other departments. So for example, we're linking to the HDIS data set in our homelessness measures to be able to evaluate and measure homelessness. And then the mechanism to do all of this right now is in Medi-Cal Connect and will be shared, like I said, initially with plans on by June 30th, and then shared with the broader public later this summer. So we get a lot of questions about accountability and what does accountability look like for these measures. So there's 2 forms of accountability that we have for the performance. The first is BHSA accountability. So written into SB 326, there are rules about sort of being able to monitor performance over time and sort of year after year performance at the county level and be able to see if there's improvement over time and if there are adjustments to plans, if there's not improvement. And so being able to monitor that and then being able to track on the voter submissions, the Behavioral Health Services Oversight and Transparency Report. But initially, we will not issue corrective action for performance until after the second integrated plan period. In terms of Medi-Cal accountability, we already have some mechanisms in place for Medi-Cal accountability in the performance measure set there. And we would look to potentially add some measures to that set over time as we continue to see progress. Mostly, we would consider adding HEDIS measures or some of the access to care measures that are already being developed. A key thing that I haven't mentioned before is that the majority of these measures that we're including are de novo measures, so they're not already established measures that happen in an NCQA or other places. So we're really doing a lot of sort of measure development in this work. So far we've identified 43 measures across the first 10 goals and are working now on the last set of measures. We will release the additional measures at a later date. We also plan to release the measure specifications for access and availability. So I have a couple minutes left, and I'm just going to flash on the screen the initial measure set and give you a sense for how the measures are set up. I won't talk through each measure specifically, but generally, these are the 4 measures that we have for homelessness. For all of our, for most of our measures, we try to have a population level measure that we call the goal level measure at the top. And so for the measure, it's the homelessness amongst people living with significant behavioral health needs compared to the overall population who are homeless. So this is sort of looking at the proportion of people with behavioral health needs compared to the broader population of people who are unhoused. Um, then we have a sub-goal measure, and this includes permanent housing for people living with behavioral health needs who are experiencing homelessness. This is more of an outcome measure at the population level. All of the measures can be stratified by managed care plan and behavioral health plan, but really the population level measures are meant to sort of help guide population level changes over time. Then we have the intervention level measures, and that's really where the majority of the accountability lies, because those are the measures that that plans have much more influence over and affecting change. So for these measures, these are things like providing housing services or providing FSP and housing services for people experiencing homelessness. These are the measures for institutionalization. And just to say, you see the goal level measure for institutionalization. It's essentially descriptive statistics for people who are experiencing institutionalization. And part of the reason for that is that we don't have very good statewide data on people in institutions, on how long they're in institutions for, what settings they're in, who are those people who are in languishing in institutions. And so we wanted to start by just collecting baseline data at the population level, and then from there down the road could anticipate looking at reducing length of stay or targeting specific populations or something like that. We have coordinated specialty care. Transitions of care, which we heard is really important in terms of providing those services to get people out of institutional stays, and then follow up after hospitalization and follow up after other institutions. Justice measures, again, there's a population level measure that's similar to the homeless measure. There's a recidivism measure, and there's 2 intervention measures that are measuring the justice, the Cal-AIM Justice Involved Reentry Initiative. The last measure is measuring medicated assisted treatment for reentry and initiative enrollees. And then in terms of reduction of children from home, we have a population level measure of children in foster care, and the interventions are specialty mental health services in alignment with the KDA benefits, core clinical services for pregnant individuals, parents, or guardians living with significant behavioral health needs. And a key note on that measure is that's not only for people in the child welfare system, that's for the entire Medi-Cal population. So looking at providing services for parents and pregnant individuals with significant behavioral health needs to be able to support the parent and family, and then high fidelity wrap. One of the things that you'll see in the measures is the definition. We had to write definitions for all of the measure components, including what do we mean by significant behavioral health needs or behavioral health needs. And so we've developed logic for all of that in our data. How am I doing on time? I could share more, or I could stop and answer questions.
You're doing good, Anna. Maybe another five minutes.
Great. Okay. So this is now entering into what we call cohort 2. So this is improving behavioral health conditions. So this involves or includes 3 different goals here. These are access to care, untreated behavioral health care, and care experience goals. And what we did here again is it's a little bit more narrow than how the department has previously measured penetration and engagement rates. So this is really focusing in on core clinical service one or more core clinical service or three or more core clinical services for people with behavioral health needs. So historically, the department has measured penetration rates as accessing one behavioral health service and included in the denominator was anybody who was in Medi-Cal. We've rarely narrowed in here on the population to people with behavioral health needs. And then we've narrowed in on the kinds of services that we want to count that include outpatient services and exclude things like ED visits for behavioral health or phone calls to schedule appointments. So really narrowing in on, did people get a treatment kind of a service? And then incorporated here, we have a couple of the NCQA HEDIS measures for initiation and engagement in SUD services. We have a couple care experience measures, and those are the current measures that are being collected by the department. We've chosen specific questions from those measures that the department felt and the committee felt were most relevant. And then we have depression screening and follow-up for adolescents. So we wanted a screening measure, and we've chosen an NCQA screening measure. We have an FSP access measure, and then a follow-up after emergency visit for both substance use and mental health needs. We also have, one of the goals is improving treatment and prevention of co-occurring physical health conditions. And so we've chosen three measures here that are really just focused on, did people with behavioral health needs get access to primary care? So we have one measure for adults, one measure for children. And then the third measure is dental care, which we heard a lot over and over from advocates and others, how important dental care is for people with behavioral health needs. And so we've included a dental care measure here. In terms of suicide, we have three measures. So we have a broader population level measure of the people who died by suicide. And then we have people with repeat non-fatal self-harm or suicide attempts, as well as follow-up mental health services after crisis, which is a HEDIS measure. Similarly, we have for the overdose measures, we have a population level overdose measure, and then a people with repeat non-fatal overdoses. And then contingency management measure, psychotherapy for opioid use disorder, and follow-up after high intensity care for substance use. And then that's the end of the measure set for cohorts 1 and 2. So this is what we're working on now and sort of the timeline and the next steps. And I think that's end of my slides. Okay. I'll stop sharing.
Thank you so much, Anna. A lot of great information as a self-proclaimed data nerd. Fascinating. Obviously, my day job is working for Los Angeles County on the substance use side, and so I'm familiar with some of these metrics. I think it also helps to outline something that has come up a lot in commission meetings, which is kind of the notion that, there's no data in behavioral health, right? There is a lot of work that I know DHCS has been doing, particularly over the last couple of years. And I think that your presentation helps to outline some of that and how it ties together via different initiatives. I think it's also important to understand not just do we have the data, but how are we actually using the data, right? But we can kind of get into that a bit more. So at this time, Anna, I just want to thank you for that fantastic presentation. Open it up first to committee members to offer any comments or questions around the presentation.
Yes, Gary, I have, this is Mike Burnick. I just have a quick question for Anna. And I'm particularly, as you know, interested in employment. And I assume, by the way, we can follow up with you directly, but just wondered, in terms of those metrics, what sort of is the next step?
You mean for the employment metrics in particular?
Yes, the employment ones.
So right now, I didn't talk a lot about this, but the the way that we've developed our measures is to use a theory of change model to identify what are the key interventions and strategies that we think would have the biggest influence on the goal, and then developing measures from that. And so right now we've worked through our theory of change for employment as well as school and quality of life and social connection, and are in the process of selecting measures with our technical subcommittee. The technical subcommittee is currently voting on a set of measures, and we'll bring those measures back to the public meeting of the Quality and Equity Advisory Committee in the middle of March. And so we propose to have a set of measures there. We're also engaging with the EDD and Franchise Tax Board to discuss acquiring some data sets to be able to link. And just to say, I think happy to have further conversations. I think, there's a lot to understand in terms of what is the role of our public behavioral health system in supporting employment. And so we're thinking about some of the tools that the system has at their disposal, including some of the evidence-based practices that are really in particular supporting people with
Well, severe mental health illness.
who
Yeah,
would benefit from specialties. Yeah.
I'll connect with Gary. I'll connect with Anna offline. I used to head EDD, so I could possibly help with that data, but also been doing a lot of research this past year and reaching out to various counties to get an idea in terms of what they're doing in terms of employment. So I'll reach out to some of them.
Thank you, Commissioner Bernick. Also, Anna, is it HCI? I imagine they might also have some workforce data. Is that correct?
HCI has workforce data. There are some limitations in its utility for this purpose, but yeah, it might help with some of our health equity work.
Great, thank you. Other commissioners?
Commissioner Bear, I have a question. Great work. It's amazing work. I just have one question. What is our plan as a commission in this work to measure the gap between the people these metrics track and then the people we're actually losing in the system, especially in the climate we are sitting in today?
And that question, Commissioner Bear, if I'm interpreting right, may be kind of, it may be both for DHCS as well as you're talking about the commission in terms of how we're measuring the impact of HR1, for example.
Right, but this information, there's the overlay of the immigration. I mean, I know, there's just scared of, giving anyone information. So how has that overlay affected your reporting?
I can speak to that just a little bit if you like. I will say that where we're hearing that come up the most is in our health equity work, and in terms of sort of the fear of disclosure and then the subsequent gaps in the data because people don't want to share status. I think it's a real discussion that we're having with counties and plans right now in terms of how the data is collected and where it's stored and all of that. And I think at the data level, we can watch over time. In parallel to that, there's a lot of work being done at the department with HR1 and being able to use data to support work eligibility efforts, which I won't speak to in the context of this conversation.
And Commissioner Baird, just speaking from one county perspective, in Los Angeles on the substance use side, we've both heard from providers who are reporting some of our agencies serve, 30 to 40% of their clientele are undocumented individuals, right? And they've reported
Right.
reductions. Particularly in LA, we've had a fair amount of ICE activity. And so I think we definitely are starting to see that. We're tracking that locally. We're also mindful, particularly given some of the state changes around Medi-Cal, of what data, actually needs to get sent to the state and what data, is more just kind of local data, right? Because given the changes with Medi-Cal coverage and people with unsatisfactory immigration status. And so those are active conversations, I know, in our county. And then finally, we've had a lot of conversations preparing for some of the HR1 changes with respect to, work requirements, which, many people with mental health conditions and certainly people with substance use conditions are actually exempt from, right? But actually having a clear process that's as streamlined as possible so that those exemptions can actually go through, right? Versus someone who's eligible but doesn't know that they're exempt or whatnot. And then other HR1 changes such as the 6-month redetermination period, right? We anticipate there being some reduction in terms of people being served simply because of those administrative obstacles. Co-pays is another item that, substance use clients, for example, are exempt from, but likely will represent some barrier because, oftentimes when this is reported in the media, the exempt groups are not reported, right? What's reported are work
Right.
requirements, co-pays, and things like that. And so the community has in their mind, oh, these are barriers. I can't afford a co-pay, right? So I will just have to find another solution, right? And so I think these are all things that systems will need to contend with. I think the commission certainly plays a role in that as well. I really do appreciate that question. Commissioner Fernandez?
Yeah, I want to second everyone's feedback on this. I think this is wonderful. I'm so excited to see the updates in terms of some of the measures that we're collecting. I have a question that will probably be completely uninformed, but I am curious about, and it's on the last couple of slides around suicide measures and overdose measures, and I'm curious to know, and I'm sure as a sort of statistician, you'll have a quick answer for this, which is how do we differentiate between accidental overdoses, overdose deaths, and suicides? And Garrett, Commissioner Sy, I'm sure you have some feedback on that one too. So I apologize, but I imagine maybe it's a thought that others have, and I'm curious to know.
That's a really good question. So the data that we're using is, like I said, both claims data and for these measures, data that's from CDPH. And so CDPH has mechanisms in place that that account for the for what you've asked about. For it, they can't account. Nobody can account for intentionality, right? But can account for uh, repeats, and it's one of the reasons that we didn't explicitly include intentionality in any of our measures, and so didn't include accidental versus non-accidental. We really wanted to focus on the outcomes and and included the repeat measure because see that as a key opportunity for the healthcare system to intervene. So a person who has had an incident of either overdose or suicide attempt the healthcare system should at that point be very activated and involved to support that person. So I don't know
Yeah,
that I totally answered the question, but yeah.
this is something that in LA we've explored with our medical examiner. And medical examiners and coroners are the ones where they categorize the deaths, right? And ultimately that goes up to the California Department of Public Health. And the way that they categorize deaths, as Anna had mentioned, it's not 100% precise just because they can't always account for intentionality. However, there are instances where there will be clues, right, whether a note or whatnot, where that will help them determine contributing causes to the death. And so that is part of what informs the differentiation between, suicide numbers versus overdose numbers. Certainly, it's going to undercount instances where the overdose may have had some intentionality with respect to suicide, but there wasn't a node or really any other clues, right? So, it's probably in all instances everywhere. This is not specific to California. The best data that we have around overdoses and suicides.
I appreciate that. Thank you for the clarification.
All right, and we're going to move over to the community comments soon, but any other last comments or questions?
I have a question and a comment, and I'm sorry, I can't find my raise hand, so I apologize for that. So I keep doing this, so sorry. Sorry, Commissioner Sai. Just a couple things. To Commissioner Fernandez's point, I also had that question. I sit with our child fatality board, and it's always like, wait a minute, hold on. But to what Commissioner Sai said, there are very clear parameters and checklists that the office uses, and so, but it's exactly that we question it too. So appreciate your response, Commissioner Sai. Anna, fantastic job. Appreciate you being here and sharing this with us. One of the things that keeps coming up when we talk with our school groups and the Department of Education is there's a big concern with those in cohort 3 when we talk about engagement in school. And the question has been like, well, how is that being measured? And people keep talking about like the California Healthy Kids Survey, right? And maybe it's something like that, low hanging fruit. It's one of those surveys that are most commonly used. However, we've seen a huge decrease in utilization of that, given the climate. Many parents are pushing back. They don't want to be answering these kinds of questions. So there are some groups that are starting to collect other surveys, data points that they want to lift up to help inform, because they're really concerned about how are we going to be measuring engagement in school. So, and talking to the CD about this. So just wanted to say that we appreciate that, this is on there, right? That this is even a measure. And then looking to how are connecting social connection and quality of life of our youth into this whole paradigm. So appreciate that. And also the self-harm and the suicides, having the age at 10, because we absolutely see that it's happening younger and younger. And we appreciate that we are doing more suicide risk screenings in our elementary schools than ever before. So I just want to acknowledge and appreciate that we're being thoughtful of that. So thank you.
Thank you, Commissioner Madrigal-Weiss. Any other commissioners before we move on to public comment? All right. Thank you, everyone. Seeing none, I think it's clear. Should we open it up for public comments?
Thank you, Chair. We do have one in-room comment, and at this time we have 3 online comments. So we will start with our in-room comment. Please make your way to the podium.
Testing. Hi, I'm Ash Wilhelm. I pronouns are they, them, and coming from Oakland, Alameda County with Safe Passages, macro MSW intern. Just wanted to thank you for your comprehensive and very deeply data-driven presentation. And also wanted to point out that on one of the slides, it talks about using data to identify and track racial and ethnic disparities in behavioral health outcomes. And of course, health equity was stated as being incorporated in all of the behavioral health goals. And that throughout the presentation, we noticed that there weren't any references to BIPOC or LGBTQ plus populations, and feel that those must be utilized in order to actually reduce those disparities. which I thank Commissioner Bear for their comment as well, or question, because I think that is connected. Thank you so much.
Thank you, Ash. We'll move to online comments now. Lisa, please go ahead and unmute yourself.
Great. Thank you, Anna. That was a great presentation. I'm Lisa Tadlock, and I'm with the Office of Youth and Community Restoration under the California Health and Human Services. And these meetings are really great. The only question I had is on the metrics for the justice involved piece. Is there a way to include or a separate question to youth versus adults? Because it feels like it's grouped together, and it would be great, particularly for our purposes in our office, is if we understood a little bit more and had some of that data around youth getting behavioral health services versus our adult population. So that was my only comment, was if that could be added, just to separate youth and adult.
Yeah, maybe I could just speak to both the past two comments. So all of the measures will be stratifiable by age, race, ethnicity, gender, and I think language, don't hold me to that, and some other key demographics. And so the idea is that at the county and at the state level, we'll be able to look at all of those stratifications for all of the measures. So we didn't, in many cases, include separate children and youth measures unless there are key interventions that are focused on children and youth, such as wraparound services, and instead focused on the ability to stratify the measures so that we can understand if there's age variance across the lifespan, as well as demographic, race and ethnicity disparities.
Thank you. Our next online comment is from Norit. Norit, please go ahead and unmute yourself. Thank you.
Hi, this is Norit Adamasu again with NAMI Urban LA. Thank you also for your presentation, Anna. I appreciated the walkthrough of some of the metrics that you presented. But going back to what you shared regarding the timeline for the plan, the integrated plan drafts, I just had a couple of questions. So one is just a note that with this year's process, given that there's been this huge shift towards BHSA, the community engagement piece has looked really different when drafting the integrated plan. I've been a member of this community planning team for LA County DMH for a couple of years now, and it's been kind of night and day, simply because I think the template for the draft has been a lot more prescriptive, and given, just the timeline for finalizing some of the details with the structure has really truncated the engagement timeframe for the community and made it a lot less possible for things like consensus building and having a little bit more direct feedback on how the plan is drafted. So that shifts a lot of the importance of, what implementation looks like to the monitoring phase of the plan. And so with that in mind, since there is a lot less engagement in drafting it, it really puts a lot more importance on how we are watching how it is implemented and how we're tracking those metrics. And I noticed that you mentioned that there will be after the voter and other ways of evaluating how the rollout has been going, there won't be corrective action that's issued until after the second year. So I'm wondering about the rationale behind that, and also what are the avenues for course correction if it's, if they're just, some bumps in the road with how it's implemented and we're not finding that it aligns with what communities need, especially in a time of heightened mental health stressors. And, the list is very long for what contributes to that, but, we're watching very closely, and we want to be a part of ensuring that this aligns with what the community most needs. And why people voted for BHSA. So that's my one question. And then another comment is just related to accessibility. I'm familiar with things like Boater and some of the metrics that you used. But as we think about community accessibility in this space and wanting to have more people at the table, I just wanted to make a note to please try to explain some of the acronyms, just because not everybody's able to keep pace with some of the information that's presented, and some of those people are the very people that maybe are historically left out of these conversations.
Thank you. We have one final online comment. It is from Allison. Allison, go ahead and unmute yourself. Thank you.
Hi, my name is Allison Walensky. I am with the Long Beach Department of Health and Human Services. We're a local health jurisdiction in LA County. And one of the things that I think consistently comes up, I'm also a part of the community planning process and a member of the CPT in LA County. And while we look at the metrics that are going to be measured, I think it's great and aspirational, but the systems across a county like Los Angeles are not set up to be integrated, and to collect that data in an integrated manner. One of the best examples that I have is the homeless services continuums of care. We have several in LA, and they're not integrated with the county behavioral health system. I know Long Beach specifically, our COC does not have integration with DMH, LA County DMH. And so I'm very curious if there's a plan to support counties in that aspect of things, in systems integration for data collection purposes, especially to ensure that all communities are being accounted for. I think that's my biggest question or comment on the metrics. But I also wanted to point out that, as Nurit mentioned, we do have a lot of stakeholder involvement and engagement. And unfortunately, due to technical errors, LA County was not provided with, the stakeholders were not provided with the draft IP prior to submission. So I am curious about how engagement will be ongoing with stakeholders, and just wanted to bring that to the commission's attention. We know we can still have public comment, but as of right now, there's no plan for stakeholders to remain engaged in the, iterations of the draft prior to finalization. Thank you.
Thank you, everyone. That was our last public comment.
Great. Thank you very much for those public comments. Anna, thank you for joining us. I don't know if you had any last comments you wanted to make before we move on.
I don't think so. I appreciate you having me, and happy to share as this continues to unfold over time. Actually, let me just make one comment, which is that to the point of sort of accountability and monitoring over time. I think because of the fact that this is brand new for the state, for the department, for our partners, for the plans, the measures for the most part are the majority of them are brand new measures. We anticipate a lot of sort of monitoring and improvement over time. And it's one of the reasons that we haven't yet set benchmarks for the measures, the de novo measures, because we don't know yet what the initial calculations will be, what the opportunities for improvement will look like, the scale of improvement. We have a lot to learn in this process. So we're starting, and I think it's a good place to start, but there's a lot to watch as this unfolds. So.
Thank you very much, Anna. And I see a hand from Commissioner Cross.
Yeah, so I did a presentation on just like Black culture and mental health, and I used the Office of Minority Health in my research when I was talking about suicide. So I just wanted to look up a couple like data points as to how they figured it out. Um, I discussed how Blacks were most likely to actually attempt suicide, and whites were more likely to contemplate it, but not follow through with it. And the data came from the National Vital Statistics System, the CDC injury statistics, and the Youth Risk Behavior Surveillance System. That one is specifically data coming from high school students for ideation and attempts. So I just want to like grab that for you real quick because I did have to do a presentation on it. And that definitely like struck me. And I was like, wait, I was like, I did that already. Let me like compile what it is that I have found. But yeah, I definitely discussed death by suicide, and that was a really hard topic to go through. But yeah, I did do some stuff for that.
Thank you, Commissioner Cross. All right, so with that, why don't we move on? We're doing well in terms of timing. Agenda item 6. So this is a discussion about the commission's data framework. So just to kind of contextualize this, right? We just spent the last 45, 50 minutes or so on understanding the state framework for data. Now this presentation is moving to focus on this commission's data framework. And so this is a good opportunity to hear from our commission staff, and is intended to support the commission as it considers future directions and priorities around its data strategy. I'll invite Melissa Martin Mullard, Deputy Director of Research Evaluation and Programs, as well as Kaylee Patterson, Chief of Research Evaluation and Programs, to give this update. Welcome. Oh, and I think we'll try to keep the similar to the last presentation to 30 minutes or so. Make sure that we'll have some time for comments and questions. Thank you.
Thank you, Commissioner, and good morning, everyone. Again, my name is Kaylee Patterson. My general title is Chief, but I currently actually mostly oversee the Commission's data team, and so which is one of the reasons why I'm here to represent the overarching data strategy for the Commission, but recognizing that it is a joint effort among the Research Evaluation Programs Division. And thank you for that setup. I want to thank Anna again for joining us and giving that kind of more in-depth overview of the work that DHCS is doing. We, for this presentation, are actually going to zoom out a bit, and while any one of the topics we'll be discussing we could spend the entire time just on one. So today we're just starting by giving just a really high overview of the framework that we use to guide our data work and to help bring some of our new and even some of our longtime commissioners up to speed with our existing work and some of our capabilities, and really to drive some of the discussions going forward on how we can continue to leverage data to drive the Commission's mission. Okay, so just really quick overview of what we're going to try to accomplish in this short amount of time. So first, we want to just ground everyone in the areas under the BHSA where the Commission plays a data role. Also understand how the Commission thinks about data and how it uses it to inform and evaluate its work. We are going to review some of the specific data tools and capabilities we have currently and some of the products that we have in our portfolio. And then hopefully end with a discussion to just consider how, given the broader landscape of data, behavioral health data initiatives, such as the one we heard about earlier from DHCS, and the Commission's roles and responsibilities under the BHSA, how can we continue to use data in a way that helps us drive our mission and also fill some of the gaps in the data landscape. I'm not going to spend too much time on this slide. The take home here is that we wanted to convey the kind of broad definition that we use when we think about behavioral health data. So earlier we were talking about data more specific to behavioral health service systems, and which is a very important part of that of the data landscape. But we also pull from other sources such as public survey data, and data from non-traditional behavioral health systems, including social services, education, and others. We also rely heavily on qualitative data and other types of information to help represent the voices of people with lived experience and perspectives from diverse communities. And we also use what we would consider process or system level data, so data that tells us how programs and services are being planned, how they're being funded, and then also reporting data such as the data we receive from our grants to demonstrate progress. And we use this data to help us identify needs and problems that we want to address, contextualize those needs by identifying the context in which the increased risk and disparities, also establishes an evidence base that point to promising solutions and helps us identify gaps to implementation. And then finally, we use data to assess and evaluate the efficacy and impact of initiatives, both the Commission's and the broader Behavioral Health Services Act funded initiatives. Okay, so this slide gives an overview of some of the areas where the Commission plays a data role under the BHSA. The Commission just in the law, it actually describes the Commission as established to use research, evaluation, and methods to track progress in order to drive transformational change in the behavioral health system. So in the description of the Commission itself, there's a big emphasis on data. And then it also states that the Commission uses that data to inform its grant initiatives, to provide technical assistance to county behavioral health, specifically around the planning process, and then also to evaluate various programs and initiatives under the BHSA, such as full service partnerships. The Commission also has the authority to, or is authorized to request data from other state departments. So Department of Healthcare Services is one example. And then also the Commission has various data reporting requirements to the legislature. In addition to the specific data elements, there's also data plays a role in the Commission's consulting role as it works with other departments to help shape some of these standards and evidence, best practice guidelines for behavioral health services. And then I also already mentioned technical assistance, but there is a specific role related to supporting counties, and data is one lever to support the local planning process and needs assessment. Okay, so to guide all the Commission's various data roles, it applies this, this framework that has kind of 4 key domains. So the first one, and all of these are used both to, these are areas where the Commission can, that support the Commission's ability to collect data, but also, and these are areas in which the Commission uses data and applies it. So the first component is engagement. So we work diligently to co-design our data products with key state partners and stakeholders, as well as community members, through ongoing and reciprocal engagement. We also, of course, use data to inform, so to promote transparency and public awareness about behavioral health services and trends, and also to just be transparent about the work that the Commission is doing. And then we also use data in our planning process and to inform our decision making. So you'll see this, for example, in the way we develop the scope of our grant initiatives and identifying populations that we serve. And then we also use it to inform some of the other in the spaces where we inform legislation and policy. So we always use a data framework to develop those recommendations. And then lastly, we of course use our data to both track progress and to evaluate the impact and lessons learned of behavioral health initiatives. Okay, so now we're going to get a little bit more into the exact work that the Commission is currently doing. So I've mapped out some of the main activities and initiatives of across this framework. So for under engagement, you'll notice we have our interagency data partners. So this is where the Commission enters into interagency agreements with key state partners, Department of Public Health, DHCS, HCI, and others. And I'm going to talk about this in more detail later, but the point here is to demonstrate that we are engaging deeply with these departments in both data collection and validation and analytics. We also work very closely with and I mentioned this earlier, with our public partners and stakeholders and members of communities, both in our data collection process, but also you will notice it as we elevate data. We elevate these perspectives in our actual data products, and to try to further strengthen our findings. And you'll see our dashboard suite is one way we use to inform and disseminate information out, as well as our various reports and even our public meetings. And then I already talked about how we use planning for our grants and to support policy recommendations. And then we have our evaluation initiatives. And I'm going to talk about some of these in more detail later on. So I'm going to go ahead and go to the next slide. Okay, so really the heart, or one of the biggest foundational elements of our data framework is our data warehouse. Essentially, this is a high security database where the Commission stores and manages all of the data it receives through its various interagency data agreements. So currently, we receive data from the Department of Healthcare Services related to behavioral health services and client characteristics. We also receive data from HCI, so that's hospital data and emergency room data. We get vital statistics data, so birth and death records from the Department of Public Health. We receive wage data from the Department of Education, or sorry, Department of from EDD, Employment Development Department, sorry, and then also from the Department of Justice, and then CDE as well, excuse me. And the question mark here just represents that while we are proud of the breadth of our data warehouse, there's other data that exists that we would love to consider and are considering exploring those additional data agreements. One example would be the Department of Social Services, but there are others. And so, excuse me. The data warehouse itself is really built mostly around the data we receive from the Department of Healthcare Services. So that represents the service level data going back currently to 2000, and I had to write some of these numbers down, so let me make sure I'm saying that right. So starting in 2000 up till now, we have just about 4 million distinct client records in that data set. That is our longest, that is the data set that we have the most data for, but when we're looking at all of our data combined in the data warehouse, we have at least 15 years worth of data for all of it. And then we actually, the exciting part about this data is we can, because it's individual level, we can link it. So it allows us to track trends across these systems and over time, while also considering demographics to identify disparities. And it really paints a really comprehensive, holistic depiction of the behavioral health consumer population. And it has hundreds of data elements. It's very comprehensive, and yet we have only really tapped into a fraction of what it has to offer. So again, just another really exciting part of the work we do. So in addition to service data and data we receive from public sector departments, we also went up, to the extent possible, in all of our work, we bring in a diverse set of data from, in different formats and from different sources. So this could include, and I discussed this earlier, but we try to what we call triangulate our data, our analytics process by bringing in qualitative data, fiscal data, public survey data, so and population level data, and we also can incorporate the data we receive from our grant reporting. And here are just some examples of the work we have done and are doing currently. So we have our full service partnership evaluation, which is legislatively mandated. And so, if you've had a chance to read that report, you'll see how it really brought in, combined many of these data elements that I discussed. And another really good example right now is under planning. So if you think about the way we plan our grants and shape those opportunities, peer respite has been a really good example of how we started early on to build, bring in secondary data, do key informant interviews, site visits, and using some of our existing data that we have on hand to triangulate this, to really produce a storytelling narrative where we can identify the problem, point to solutions and come up with a plan for how we're going to shape that funding. And that eventually will lead to the framework that we use for the evaluation of that initiative. And then again, policy is another area where data does play a big role. I've listed here some of our most recent policy reports, which again combine many different types of data sources. But I also want to point to, actually that's not listed here, is the initiative the Commission is leading for the to sponsor legislation related to requiring suicide prevention training in schools. And in that, there is a big emphasis on data collection and reporting in a standardized fashion, which currently does not exist. And that work was informed by some of the previous work the Commission did specifically around universal screening in schools, but also demonstrates another way the Commission works to enhance, data capacity in the state, not just through its analyses and data products, but also through some, in the policy space. Okay, so one of our most, I think, one of the products that the Commission is most familiar with is our public-facing data dashboard, so our transparency suite. And so right now, actually, I'm going to show you a glimpse of what that is. Okay, great. So these are our existing dashboards that many of which predate the BHSA, which is important. So I don't want to get too far ahead of myself. I will come back to that, but it's the data here. We have not updated for the BHSA because that data is just simply not available. But anyways, you'll notice that we cover a number of domains. So we have a fiscal transparency dashboard. Client services information involves the data I mentioned earlier that we received from DHCS. I can click on that if you'd like. So this is just an example of how the Commission uses the data in its data warehouse to to track trends in a public-facing platform. And this one is just related to client and service information. So these are local behavioral health services under the BHSA, and we can map it out across counties and across time, and there are other various ways to kind of to look at the data. You can do it by region, county, etc. And let's see. 10 more. All right, so I encourage everybody to explore this on their own. I just wanted to point to where it exists on our website. And okay, so Coda, we can actually go back to slides now. Okay, great. Okay, so let's see. So baked into the Commission's data framework is also an ongoing process to ongoing engagement and quality assurance process to ensure that our data is valid, relevant, and inclusive. I want to just make a nod to one of the public comments we received earlier around, make the importance of making data accessible, because recognizing that there, even just the people in this room and online, but just in general, there tends to be a wide uh, um, distribution of levels of data literacy and comfort and its use, and also in terms of knowledge of how to use it and apply it. So, as much as we can, we try to make our data both meaningful and valid and relevant, but also really easy to use, regardless of your background and education. And that's certainly an area there's always room for improvement, but it is one of our one of our goals. So some of the ways we do this, of course, is by turning back to really leveraging our engagement strategies, not just with our interagency data partners, but turning the data around back to the community and stakeholders and allowing them to be active participants in shaping, vetting, and improving our data products. One example of how we can do that is through our dashboards by building in a public review process where we can sort of put out a test version and then have a transparent way of how we will collect that feedback and incorporate it into the dashboard itself. We also will, have ways to assess the reach and impact of the data products we have by tracking how people are engaging with them online and such. And then also, of course, updating our data as the behavioral health landscape evolves. Okay, so how much time do we have? 8 more. Okay, cool. So we are very excited to now talk about some of the things that we have in the pipeline. We have been working for a long time on 2 different sets of dashboards. One of them is our population behavioral health measures dashboard, and actually this dashboard was developed in response to and in collaboration with the work that DHCS is leading around the behavioral health transformation goals, and some of the phase 1 measures that they defined, and those data sources. And I'll link on these in a minute. But the second one is using data from our data warehouse and our linked data to look at educational characteristics of young people who are receiving MHSA or BHSA funded services. So let me go ahead and click on, I'm going to start with the education one. Cody, would you mind letting me? Thank you. So this is just a glimpse of the education dashboard. And as you can see, it's attempting to look at academic engagement and performance measures among young people who are in school and receiving specialty mental health services, and then comparing those trends to the general population. So we look at things like chronic absenteeism, dropout rates, suspension rate, graduation rate, and then other standard metrics. And then we can look at how those individuals are doing across the state. We can look at it by county. Oops. And then we can break it down by oops, sorry. I have a little bit of a lag. So we can look at it by the all CSI engaged or behavioral health service engaged youth, or we can also drill down to just looking at those who are in a full service partnership program. This data goes back to 2016, 2017, and so it allows us, so again, to look at those changes over time. I think what's really important or interesting here too is we would expect that students who are receiving specialty mental health services would likely perform less positively than the general population. So, but what is for some of these measures, what's interesting is that when you see over time, even though there remains a difference, that difference begins to close. So that could suggest that some of the investments over time have actually improved outcomes for the behavioral health student population by closing that disparity gap. It's just one example of how this data can be interpreted. Okay, and then this is our excuse me, let me put the Okay, here are our population behavioral health measures dashboards, and this is actually a set of dashboards. And again, you'll see they are organized by the domains identified by the Department of Healthcare Services as part of their performance measurement strategy. And then so I will go into, let's do overdose. So they align with the statewide goals. And then we have taken it a step further. So all of this is also based on publicly available data. So this does not include data that is in our data warehouse. So we've been able to show, again, we have a time trend. We can compare a county to the state average rate. And then we can also look kind of at a glance across the state to see how counties compare to others. And then we can also break it down by demographics. And this one is drug-related overdose deaths for people, for all Californians. And so this is just one example of what these dashboards look like. But often for a domain, there'll be multiple measures.
Thank you, Kelly. Maybe 2 more minutes.
Yep, great, thank you. So we have a tentative plan for how we would like to release some of these new dashboards. We plan to present them to the full commission in March, and then potentially release them for a 30-day public review period where people would be able to log in and use it and ask questions and provide feedback before the dashboard was finalized. So that nearly concludes my presentation, and it was definitely covered a lot, and so I hope there will be questions and even more opportunity to dive into some of this in more depth at a later time. But I want to just point to some considerations for the committee as it responds to the presentation. We're hoping that there's so much we can do with our data. As I said, even the data we have kind of just hit the tip of the iceberg in terms of what we could do with it. So we would love to have more engagement with the commission and to have them think about, in consideration of their responsibilities under the BHSA, and their upcoming strategic planning. How and where should the commission be really focusing its data work, or how can it refine, and how can we leverage our capabilities and our data warehouse? Is there other data we should be considering? What are the considerations? Like what resources are we going to need to fulfill that role? And I want to point here too that as Commissioner Tsai mentioned earlier, the issue is often not that data doesn't exist; it's that it either exists in a silo or it has not been used to its fullest potential. So more is not necessarily always the answer, but it's more about how can we be more intentional and precise and also inclusive as we use the data and disseminate it. And so with that concludes my presentation, and I am looking forward to hearing your questions and comments. Thank you.
Great. Thank you very much, Kaylee. Very informative. Let's open it up to committee members. Any comments, questions? And then we'll open up to the public after that. Anyone?
Pam, I have one, sorry. Thank you, great presentation. And since we're on committee, I'll get a little bit in the weeds, but going back to the current federal environment, the data sharing agreements that are in place right now, is there a formal privacy risk assessment on that integrates into what is actually exposed? Sorry, it's kind of in the weeds, but kind of traceable and targetable in a way that is protected.
That's a really good question. We do, and Melissa, feel free to chime in too. We do practice already very strict security practices to ensure that our data is not identifiable or traceable and is highly protected, both through our internal data administration practices, but also in the way that we disseminate data. So, for example, we have certain thresholds for regional data that if it is below that threshold, we will not even report it because there's a potential for it to be traced. As far as the federal, the concerns that are coming out of the federal climate, I think that is a really interesting question that I would love to explore more because it is certainly unprecedented. But I appreciate the sensitivity to it, and I don't yet have a specific response to that.
Hey, Kaylee, just to follow up. Oh, sorry, Commissioner Bear.
No, and just taking it a little bit further, is there a company that exists, whether it's preferably in California, that would be a significant resource to you where you sit in doing your work?
I'm not sure I understand the question.
Well, a significant mission-aligned company that's it's probably on the private sector that is aligned with what you're doing, that maybe as commissioners that we can open some doors for you. I'm just thinking from a public-private partnership in a way that we don't know this company on the data innovation and to get you to where you need to get to sooner.
So what I'm hearing is there a company or a tool that could be helpful for the commission in terms of managing its data and what its data priorities are?
don't think in terms of the data management component, but I think that we're certainly open to having conversations about how we can maximize our data analytic capabilities. Our team is small, but we feel like we have a lot of capabilities and internal analytic kind of chops. But I think one example of how we're leveraging an outside company is our work with WestEd to help support our BHSSA, our Behavioral Health Student Services Act grant project. So we recognized that with a $300 million investment, we really didn't have the internal capability to do everything we would like with the data analytics and a comprehensive evaluation. So we carved out of our, not out of our local assistance dollars, but we had BHSSA evaluation dollars to support our internal capabilities. And so we try to make sure that for our grant making that we're carving out dollars to support our internal evaluation capabilities. So I know that doesn't maybe quite answer your question, but I guess the answer is we are already working with other entities to support that, and I think are open to other suggestions that commissioners may have for further partnership with outside entities.
I can add to that too, if that's okay. I would say that, other than making our products really fancy, I think, one area that is, I mentioned it earlier, is data accessibility. There's a lot of work to do, I think, in both the private and public sector in terms of making it more user-friendly. And so I think there's a lot of space for innovation in that sense, especially for people of various abilities and languages that we don't tend to. We put a lot of energy to make other types of our material accessible, and data seems to be one that hasn't quite caught up to some of those standards. So I think. And I don't necessarily know think we have all of the current resources to do that currently, so that could be one thing to consider. I'll also say that an ongoing trend in our across the board is data quality, and that's often outside of the control of the commission and staff. So when I say data quality, that could be the data that we receive from that counties report. There's been historic inconsistencies in it just even being reported and the completeness of it and the consistency across how it's reported. So there's a lot of variation. It makes it really hard to then do a state level evaluation. I believe that was one of the main learnings from the FSP evaluation, for example. So, and we see that in other areas as well. I think, earlier we were talking about death by suicide data, and yes, the state Department of Public Health has their own methodology for making the distinction between, an accidental overdose, for example, versus an intentional death by suicide. But the fact of the matter is it really depends on the coroner, because they're the ones that are filling out the death report. And there's a lot of room for interpretation and a lot of gray area. So it kind of starts there. And again, that is way outside of the purview of the commission, but certainly an area that, and we have discussed this with, the Department of Public Health as well, an agreement that there's work to be done there. So it's just another example of how granular you can get. And often data innovation isn't as fancy and as exciting as we think. Sometimes it's actually going back to where we started and just making sure we provide the necessary support, for example, and technical assistance to get the data we need. Just another example is I would say there's a lot of, people talk about the CHIS a lot, the California Health interview survey, and it is an amazing data source. It's not meant to replace individual service level data, but it certainly captures data that we just simply cannot through like the data we get from service providers. And I think that, you know, exploring potentially a partnership with them and thinking about how we can achieve some of our data goals by leveraging those resources is also something to consider, and they are local. So just another thought since you asked.
Thank you, Kaylee. We're a little bit short on time. I think Co-Chair Madrigal Rice has a comment.
Yeah, thank you so much for that excellent presentation. I just have a couple questions. So my understanding is a lot of this is really trend. So, right, it's more of trend data. So as far as like having it be identifiable to a person where it would cause harm wouldn't be as likely. That's how I'm seeing this.
Yeah.
Okay.
Yes.
Yeah.
Yes.
Okay. Just my other thing is looking back at some of the dashboards, a lot of those are still kind of behind, right? So what is the plan to get it more quickly so that it can be more relevant and timely? I love the dashboard, the education dashboard. That's great. And I would like to really, you know, we can go on a campaign and share it with our LEAs, right? Work more closely with CDE so that we can be more responsive. But it's going to be important that we're gathering it in a more timely way. So, are we talking strategies with our partners with like CDE, or what is our plan? Or are we coming up with suggestions for that? Or how does that work?
Yeah, I'm pausing because it kind of depends on which data we're talking about. So actually, I mean, if we're just talking about CDE, they have their own, I actually don't know what their plan is. I would love to explore that with them of how they could maybe potentially get data more quickly. But I know that in general, at the state level, there's often administrative barriers to that, and we are sort of beholden to whatever timeline they have, and then what is required in our data use agreement with them. That said, we have, you know, with the changes under the BHSA and such, we it has affected our the turnaround of the data that we get through all of our agreements, and particularly for the local behavioral health services data, and mostly because they're essentially changing the platforms that that counties report through. So, for example, starting in 2023, we saw like a tremendous dip in the amount of data we were even receiving, and it was essentially unusable because counties were just missing data. So we are in the process right now that currently, and actually basically in the final stages of switching the data that we get from DHCS to a more reliable and complete data source, but it's required a renegotiation of our agreement. That's one.
Yeah, thank you.
Yeah, we're out of time. Let's open it up for public comment real quick. Any public comments, Claire?
No public comments.
All right, now we're back on schedule. I think Brenda or Executive Director Graylish had a comment before we adjourn.
Yes, thank you so much, Commissioner Sy. I just wanted to make a little clarification from one of our earlier agenda items, which was general public comment. Just wanted to make it really clear to folks that we can't while we were relaxing Robert's rules on all of our agendized items, the one that we can engage in back and forth comment and discussion on is our general public comment, because it's not an agendized item, whatever somebody might bring up. So, but that said, I do want to acknowledge the public comment that Nora Adamasu made earlier, and just wanted to say that we'll be following up on offline to help provide some information on the work we're doing. So thanks so much.
Great. Thank you, Brenda. We are at time. I do see one hand from public, and maybe we'll take that prior to adjourning. Laurel?
Go ahead and unmute yourself.
Good morning. I think we're used to having a little more introduction and time to get onto the public comment list, and that's why I wasn't prepared. There's usually a little song and dance that staff have to go through, so I apologize for being late, but I couldn't help it. I remember under the MHS, so I'm Laurel Ben Hamida from Muslim American Society Social Services Foundation and the Reducing Mental Health Disparities Coalition. Under the MHSA, the previous law, difficulties existed because some counties did not submit required data. Some of you will remember that. And so when the Little Hoover Commission looked at the MHSA to see if it was effective, they said they could not determine if it was improving mental health because of the gaps in data. That was sad and painful for everybody. So does the current new law, the BHSA, have any teeth or incentives to encourage counties to send you data on a timely basis in the format that you've asked for or the law asks for? And two, and this relates a little bit to Commissioner Baer's interesting questions, are you using any AI products, or are you in talks with AI companies to assist you in your work with data? And three, are you collecting qualitative data? Thank you so much.
I'm happy to quickly respond. One point of clarification is that we don't receive data directly from counties. So any data reported from counties is reported up to DHCS or CDPH or other entities, and then we receive that data from our state agency partners. The commission does not have any authority to require counties to submit that data to other state agency partners. So it's outside of my realm to talk about what teeth might be available to encourage data completion and data quality. We are not currently using AI products for our analysis. We are not closed off to that idea, but at this point in time have not used any AI analytic products. And then for qualitative data, yes, for our evaluations and our policy reports, do a lot of qualitative interviews, focus groups, stakeholder engagement, and collect qualitative data to support those efforts.
Thank you, Melissa. Thank you, Kaylee. Laurel, to your question about mandates for counties to submit data, DHCS does have regular authority to mandate certain data from counties. And so there are certain requirements kind of independent of BHSA. There's a lot more to this that we could go into, but we're already 4 minutes past. So apologies for kind of the rush at the end. Thank you, everyone, for joining today. We look forward to ongoing discussion. Have a great day.